Hey everybody, it's Elizabeth and I'm here with Watch Patti Melt and Dr. Timothy Katzen, and welcome to The Naked Truth. We are so excited. This is our first time having a non-weight loss surgery patient as a guest. So Dr. Katzen, I hope you'll be patient with us.
Oh, well, thank you very much. Certainly. Yep.
We're so thrilled to have you, and this is the first time that Patti has co-hosted with us. She's going to be one of our regular co-hosts. So if there happens to be anybody in the universe who doesn't know who she is, other than my partner in crime, I wanted her to just give a little bit of background on her story.
Okay, great. I'll start. Hi, everyone. It's Patti, also known as Watch Patti Melt, and I started my weight loss journey about 2 years ago right now in October, November of 2013, and I was at my highest weight then of 360 pounds. I decided to do OptiFast first before having my gastric bypass, and I lost 70 pounds leading up to my gastric bypass, which was in April of 2014. And then I reached my goal in July of 2015, so just a couple of months ago, and my goal was to get to half of my body weight, so it was 180 pounds, and today I'm at about 175, 176 pounds. So, and I am currently at, I lost 100% of my excess weight, so I'm really excited to be where I'm at.
That's great.
Yay. And before, just really quickly, before Patti introduces Dr. Katzen, I just want to let everybody know, I don't think comments are working again on YouTube. We have a lot of questions, but if you have additional questions, if you could post them as a comment either on my Facebook page, where I put the link of the show, or on the Naked Truths page, commenting on that specific post so it's easy for me to find them. And if they're really relevant to what we're talking about at that moment, or we have time at the end, would love to include your questions. And the other thing is we want to make the most of Dr. Katzen's time, so we're going to do community celebrations at the end of the show. So I'm going to turn it back to you, Patti.
Okay, well, again, everyone, it's our honor to have Dr. Timothy Katzen tonight. Dr. Katzen is a board-certified plastic surgeon from the American Board of Plastic Surgery. I took notes here, so let me look at them. He practices in Beverly Hills, California. He is a graduate of Duke University, and then his medical school was at the College of Virginia. He did his residency in general surgery at the University of Hawaii, and his plastic surgery residency at Vanderbilt University. And he's got a lot of personal interests. He likes to travel, he likes computers, he loves rugby, in between all the other stuff that he does, scuba, fishing, and he also is an Eagle Scout, and he enjoys land and underwater photography. He also speaks Spanish and French, and he's just a well-rounded gentleman, and we're really thrilled to have him tonight. And he's been a huge contributor to our community as a whole. He's performed surgeries on a lot of the people that many of us know and have followed on YouTube. And he's got a great heart and a great compassionate spirit. And so we are thrilled to have him tonight to answer all of your questions.
Well, thank you for having me. Thank you very much, Patti.
Thank you.
So we got a ton of questions in for you, so I just kind of wanted to jump in and ask you how you started working with bariatric patients.
Sure. It all boiled down to about 15 years ago. I had this wonderful patient, and she had lost about 400 pounds. And she was, no less, an ICU nurse in Southern California. And she had seen about 6 or 8 plastic surgeons, and nobody would touch her. Everyone said, oh, you'd lost too much weight, you need to lose more weight, there's too much skin. And I said, well, you know, you lost 400 pounds, you can't lose much more because you're dieting and exercising all the time, so let's get started. So we went on a path of a body lift, lower body lift, addressing tummy, hips, backside, then a couple of months later the legs, a couple of months later the arms and the breasts, and she had fantastic results. And because of that single patient, I become very involved with the community, and I love the patients because the patients are highly motivated. You know, they've lost all the weight, they want to get rid of the excess skin, excess fat. We see very significant results right on the table. You know, I'm removing not, 3 or 4 pounds. I'm removing, 10, 15, 20, sometimes, 50, 80 pounds of skin and fat with dramatic results. Patients are highly motivated and they see the results, and it's a very energetic community. And I love the patients. I love their results. It's big surgery, but that's what I love doing.
And of your practice, what percentage are bariatric patients of your practice?
Of my practice, having had patients who have had bariatric surgery, probably about 90%.
Oh,
then
wow.
Then I have about 5% who have lost at least 100 pounds or more with diet, exercise, etc.
So that's really your primary focus?
Absolutely. About 95% of my patients have lost at least 100 pounds or more.
So I've lost 200 and live in Orange County. I'll be coming to see you soon.
Yay, congratulations. That's great.
Thanks.
That's great.
Dr. Katzen, is it true that it's best to be at your goal before having plastics? And if so, do you need to be at goal for a specific time?
Yes and no. These goal weights that we are given by, the media and sometimes the general surgeons are ideal, and it's great, and it's a number to sort of strive for, but it's not the end all. I have a lot of patients who have come to me and they've lost a lot of weight, 100, 200 pounds, but they haven't hit their goal. And they're exercising all the time, they're eating all the right things, but they just can't get rid of that extra, say 10, 15, 20 pounds, and they're stuck at that number. No matter what they do, they just can't pass that number. So yeah, it'd be great if people were at their goal or even below their goal, but some patients just don't meet that goal, and they still would be ready for plastic surgery. Now, if you haven't hit goal, I insist you still should be about a year out from your gastric bypass or your sleeve. If you had a lap band, I insist on at least 22 months post-op to allow the surgery to work.
Mm-hmm.
And then if you're continuing to lose weight, when you see me, I encourage you to lose as much weight as your body can, and then you'll plateau. But I do have a significant number of patients who have plateaued before their goal weight.
Now, I've heard some people say that you should be at goal for a year. I mean, you don't think you need to be there for that long, just to know that that's where you're going to stay?
Yeah. I mean, if you're conscientiously dieting and exercising and doing all the right things, the surgeries are wonderful, but sometimes the body just physiologically can't hit that goal.
Right.
Yeah.
Right.
Yeah.
What about for people who have a significant amount of weight to lose, and I can never say this word. How do you say paniculectomy?
That's exactly how you said it.
Oh, is that how you say it? Okay.
Paniculectomy, yes.
Paniculectomy. Are there times when you would do that even when they still have a considerable amount of weight to lose, just because it's getting in the way of them being able to be physically active?
Yes, absolutely. Now, the paniculectomy is a removal of a pannus. Now, what is a pannus?
Mm-hmm.
Pannus is an apron. It's that apron of skin that covers up the pubic region or covers up part of the pubic region. Sometimes before gastric bypass, we'll do a paniculectomy. Sometimes during gastric bypass, we'll do a paniculectomy. Sometimes after the gastric bypass, if the pannus is pretty large, we'll go ahead and do a paniculectomy. But again, it just removes excess skin and fat that covers the pubic region. It doesn't touch the muscles on the belly wall. It doesn't touch the umbilicus. So it's really just getting rid of excess skin and fat.
And so and we're going to ask about that later, because I know personally from talking to people, there's a lot of confusion about what all these different surgeries are. But so if someone did that, then conceivably later, as they lost more weight, they might have another surgery later on.
Exactly. So sometimes the paniculectomy is done just to sort of jumpstart things. Sometimes it's done to make the gastric bypass surgery easier because you're getting rid of all that excess skin and fat. But if the pannus is not too severe, we go ahead with our laparoscopic instruments, do the gastric bypass, and let that pannus shrivel up as much as possible. But you also have to consider, 15, 20, 30 years ago, before this revolution of laparoscopic procedures when gastric bypass really took off, we were doing paniculectomies. We were doing large abdominoplasties on significantly obese patients even before they even considered having gastric bypass. So we were doing these procedures, but now with the advent of gastric bypass being much safer than it used to be, we're doing a lot more gastric bypasses.
Mm-hmm. And before Patti goes to the next question, because I'm getting a lot of messages, I know comments are disabled. I don't know what's going on with that. That's happened the last couple of weeks, and other people with shows are reporting the same thing. So if you have comments or questions, just post them on my Facebook page. Okay, Patti.
Okay. So a lot of people seem convinced that excess skin is from not working out enough, or that if they would just work a little harder at toning up, they could reduce their excess skin. Can you address this?
Yeah, that's a common misconception or misbelief. I see this all over the message boards, and a lot of patients come to the office. I get asked this a lot. With weight gain, the skin is stretched out. And if you look under a microscope, skin has elastic fibers. So the skin is stretched, and the elastic fibers in the skin try to contract and recoil. But when you lose that much weight, the skin has lost a lot of its elasticity. It'll contract a lot, but it can't contract 100%. Mm-hmm. So even if you work out more and more in diet and exercise, etc., that skin is almost impossible to shrink back to its original state. Okay, it's just because of the elastic fibers under a microscope in the skin. They've been stretched out too much. Yeah.
So when I tell myself that mine is not as bad as it could have been for losing 200 pounds because I've worked out consistently, strength trained since 6 weeks post-op, I'm fibbing myself.
Well, no. I always encourage to, diet and exercise. That's definitely part of the weight loss surgery. It's very important, but the skin can only do so much.
Right.
And younger patients whose elastic qualities in the skin recoil better than patients who are older where the elastic skin quality is not as good. So the analogy also is like pregnancy. Women who get pregnant early, deliver baby full term, a lot of that skin bounces back and there's no excess skin. But if you get pregnant in your 40s and 50s, that skin is going to hang and not recoil as much as a 20-year-old.
Interesting. What's sort of your best case scenario in terms of fitness and muscle strength prior to an abdominal surgery like this, just in terms of recovery and everything else like that?
Yeah, I always tell my patients, continue dieting, continue exercising. Just showing up for an abdominoplasty typically, or a body lift, is not the cure-all. That doesn't mean you can't exercise, or you won't need to exercise anymore. You still have to exercise. So ideally, patients will continue their exercise regimen before the surgery. I don't ask them to increase or decrease it, just maintain it even up to the day of surgery.
And Patti, I'm throwing in a lot of questions that aren't on here, sorry,
okay.
because I'm just thinking of them. One of the things that personally scares me about doing it is, so for the first time in, I didn't discover until I was, 48, 49 that I actually liked physical activity and loved to exercise. And so one of the things that scares me is how long am I going to not be doing that after the surgery?
Sure. Everybody is a little bit different, but typically after a tummy tuck, abdominoplasty, I don't want you to do significant exercise for about 3 to 4 weeks. Now, at about 2 weeks, you can walk around the neighborhood. You can even do treadmill, if you will, at about 2 weeks. At about 4 weeks, I'll have you do a little bit more, and everybody is a little bit different. And then usually at about 6 to 8 weeks, you're able to do more and more. One of my favorite stories is, a patient had a body lift, okay? And about a week after the surgery, she calls me up. She goes, Dr. Katzen, I'm walking, but I'm really, really tired. I'm like, well, you had surgery and you're taking the pain medications. And I'm like, so as we went along with the conversation, I asked her, well, how much are you walking? Well, I'm walking my normal 5 miles. I'm like, 5 miles a week after a body lift. So that's too much. Everybody is a little bit different pace, different exercise regimens. So, it's a very general question. But depending on the patient, their surgery, their recovery, you're able to resume some activities, usually about 2 weeks.
But like strength training and weightlifting, that's further down the road.
That's further down the road, yeah. Weightlifting, more strenuous exercise, that's typically at about 2 to 3 months after the surgery. Yeah.
And does age play a role? I'm throwing one in too. Does age play a role in that ability to bounce back into exercising and so forth?
Yeah, like age plays a part in everything,
Okay.
but it also boils down, I would say it boils more down to the patient than really chronologic or physiologic age. More the patient.
Okay. Are there any tips on getting excess skin in the best possible condition prior to surgery?
I wish, but there is not. You know, all I can suggest is continuing, you know, diet and exercise. That's really the best. Unfortunately, there's no lotion or cream or pill or laser yet, but maybe in the future, but not right now.
Okay. And as far as vitamins go, is there anything that you would focus on for optimum health prior to having plastic surgery?
Yeah, a couple of things in that neighborhood. I always recommend a multivitamin. I think that's, you know, very important. Also, I'm a firm believer in vitamin C. I think that's a very important key component to healing. So I think increasing your load of vitamin C is probably good. If you take about 1,000 milligrams, which is 1 gram, usually space it out either 3 or 4 times a day, you know, 250 or, you know, 350, 2 or 3 times a day to get that 1,000 milligrams a day is ideal. And then I also think eating a good amount of fish is very important. Fish has a lot of vitamins, you know, that are hard to absorb in other food sources. So I think fish is a very good source of some vitamins too.
Very good.
Yeah. And then very important before the surgery, in addition to the vitamins, maybe even more important, a lot of studies have shown this through in the dietetic studies, in the dietetic industry, a nutrition industry, that usually we like to get about 100 grams of protein in a day for about a week or 2 weeks before the surgery. Okay, that increases your protein load, and then after the surgery, I have you continue about 100 grams of protein a day. Now, some people say, well, you know, you don't need that much. Well, you do, because you need all those calories, all those protein building blocks to heal up from the surgery. And then also you need the protein and calories for your just baseline of, you know, living and breathing after the surgery. So 100 grams is a good goal. Now, the 100 grams also is not too high for your kidneys. Some physicians, some patients will say, oh, you know, that's way too high for my kidneys. Well, it's not. Your kidneys will process that. They'll filter it through. Your kidneys will be fine. Typically, most of my patients, before the surgery and after the surgery, to get that volume of protein in, that 100 grams, we'll take it in a liquid form, which is ideal. So a good liquid protein source of your choice. Yeah.
Okay. So let's talk about how you pick a plastic surgeon, because not everybody lives here where we do.
Yeah. I've given several lectures on this. I would say there are 3 key components. One, you know, I think you should be board certified by the American Board of Plastic Surgery. Now, in not just California, but all 50 states, the plastic surgeons went to the U.S. Supreme Court and said, you know, hey, you know, we have everybody doing plastic surgery. There should be some laws restricting people from doing plastic surgery that are not experienced. U.S. Supreme Court said, no, any MD can do any procedure they want within their own surgery center.
Oh, that's interesting. Oh.
Yeah, so in Southern California, we have, I know dermatologists, I know obstetricians, I know pediatricians doing plastic surgery.
Wow.
Is it illegal? No, not at all. But, you know, if I were having gastric bypass surgery, I would go to a general surgeon who specializes in gastric bypass or, you know, weight loss surgery, you know, vertical sleeve, the lap band, etc. If I were having plastic surgery, I would go to somebody who's certified by the American Board of Plastic Surgery. And that gets even more confusing. There are several other boards. There is the American Board of Facial Plastic Surgery. Those are mostly ENT, ear, nose, and throat doctors that specialize in plastic surgery, neck lifts, face lifts, eye lifts. And then they sort of morph that into, oh yeah, I do all plastic surgery, the total body. So beware of that group. And there's also the cosmetic board, who the training is not nearly as rigorous for those plastic surgeons through that board. So that's the number one thing. Okay. American Board of Plastic Surgery. Number two thing, American Board of Plastic Surgery.
Okay.
And you can check that. You can go online and Google www.plasticsurgery.org. And check your plastic surgeon's name. If he's on there, he's certified. If he's not certified.
Okay, and I'll post all this stuff in below the video when we're done,
all
so
right.
you guys can access these things. Okay.
And the second most important thing, I think, for choosing the right plastic surgeon is experience. Mm-hmm. I mean, you should not be their first patient. You should not be their guinea pig. You should not do it, oh, I'll give you a great discount if we do your surgery. You know, a lot of things can go wrong and do go wrong. I see patients from other plastic surgeons, oh gosh, you know, got to revise this, got to revise that, and have major problems. So they need experience. And the third thing I would ask your plastic surgeon is, I would like names and numbers of people that have had this surgery with you, similar to my body type. And you need that, you know, you need to talk to patients that have been through this. I can tell you everything about the surgery and how it goes, show you videos and before and after pictures and all that. But it's also very good to talk to a patient that's actually been through it. You know, how much pain will I have? Which protein drink did you drink? Am I able to do the elliptical on day 7? You know, I run marathons. When can I do marathons? Things like that on a personal level where you can actually talk to people that have actually gone through the anesthesia, experienced it from the patient side, not necessarily what the plastic surgeon is telling. So I think those three things: board certification, American Board of Plastic Surgery, experience, and then giving you a lot of names of patients that have been through this previous procedure.
Are there any particular questions other than for references that you think people should ask during their consult?
Ask the plastic surgeon or other patients?
Ask the plastic surgeon, yeah.
Yeah, I think a very important question is, you know, how long have you been doing this? You know, is this, you know, did you just finish your residency or fellowship last year? Or are you doing this like me for 15 years now? But, you know, experience is very important. So I think experience is very important. What percentage of your practice are weight loss patients? That's a very important part. You know, if it's a minority of their practice, that may or may not be a good thing. I also understand there are geographic restrictions. There may be some patients, you know, there's only one plastic surgeon in the 50 miles. But that begs the question, well, it may be better to perhaps travel outside the state to go to a surgeon who has a lot of experience. About a third of my patients now are coming from out of the state of California, and about a third of those patients come actually from out of the country. So we get a lot of patients, you know, coming from other states to see us for their plastic surgery. Yeah.
Well, that leads right good into the next question, Patti.
Yes, it does. Do you have any thoughts on getting plastic surgery outside of the United States? And we'll start with that.
Yeah, very, very good question. Now, I have a lot of friends who are plastic surgeons, board certified outside the U.S., and they're great surgeons, and they get great results. But one of the problems is if you go, and I unfortunately learned this through a patient of mine, and she was a nurse, so fairly educated in the medical community, knew doctors, knew surgeons, but decided to go outside the U.S. for her plastic surgery. Okay, there's nothing wrong with that. However, she had some bleeding during surgery, which can happen. In my practice, fortunately rare. Unfortunately, she required a blood transfusion. Again, very unfortunate, very rare in my practice, but again, it can happen to even the most experienced plastic surgeon. That's not the problem. So she got a blood transfusion. Okay. Problem is she got hepatitis C from her blood transfusion. Okay, horrible, yes, it's very, very bad. And that can happen even in the U.S. Again, it's pretty rare. But the really bad thing was when she came back to the U.S., she's a U.S. citizen, nurse, etc. Did you know insurance companies don't cover your health care if you develop a disease outside the U.S. from a blood transfusion?
Wow.
So she was stuck. She could have no access to any medical care in terms of the Hep C that she developed from the blood transfusion. So, yeah, there are great surgeons out there, great, I know them personally, and they do great results, and I've lectured on the podium and operated with them in the operating room, but coming back to the U.S. with a complication, that's a difficult thing. I also see patients come to me in the office, having had surgery outside the U.S. with some, let's say, interesting results and difficult to revise. So you get that. So, I would say I would not go outside the U.S. if you're looking just to shop for price. Yeah.
Okay. Now that's really... Yeah. Is there any kind of network or website that lists plastic surgeons like yourself who are very experienced in bariatric surgery?
That's a good question. None that I know of.
Okay.
That would be a good website to create, either within your community, or there are a couple of organizations online who have frequent plastic surgeons who post a lot of information for weight loss patients. But that's something we should work on.
Okay.
That's a good idea. Yeah, we'll create that. Yeah.
I'll add that to the list. We can work on it together.
Okay, that'd be great. That'd be great.
Okay. So, Patti, I was wondering if you're comfortable with talking a little bit about your experience of how you met Dr. Katzen and what the process has been, because you're getting ready to jump into this pretty soon.
Yes, I get to see Dr. Katzen this week, actually, for one of my pre-surgery consults. Yeah, thank you. I got all my pre-testing. I got all the pre-testing done last week, so getting ready. Yeah, thanks. And I'm excited. There's hesitancy, just the normal anxiety, but it's all good. I'm trying to just get my task list done. But to your question, Elizabeth, basically, I had done just a lot of the people in the community know I've done a lot of research for the bariatric surgery and so forth prior to pursuing it, and I did a lot of research on plastic surgery post bariatric surgery as well, just so that I would have an idea of what I would be in for long term if I were going to go through everything. So I came across several people within our community, and there's several that I would like to talk about, or at least mention. Banded Wendy and Sarah Will Be Skinny. These are all their YouTube names. Laura's Thinspiration, and then Bariatric Barbie, who is also Carrie De La Cruz. And then most recently, Jolene Wentworth, who was on My 600-Pound Life, and Dr. Katzen just recently did her surgery. And that's actually going to broadcast, I believe, pretty soon, Dr. Katzen?
Yeah, I think in January. Yeah.
Okay.
And she looked amazing. We went out to dinner with her a couple of nights before, and when she posted her pictures afterwards, that was just incredible.
Yeah, she posted one today too, and it's just
I saw that.
Beautiful. Yeah. So the beautiful thing was, not only did I get to see these people's videos, but then I went to an event that was sponsored by the WLSFA, and it was a documentary on a group of ladies who were having bariatric surgery. But I met Dr. Katzen and his group there, and I met a lot of the ladies who had had surgery by Dr. Katzen there. And I just really liked his compassionate heart and his empathy for our community. And I've met with him a couple of times. I've had a consultation with him. I've met him, let's see now, 4 times. And every time I just feel really, really comfortable with Dr. Katzen. My husband has met Dr. Katzen several times. And we just know that he is going to take great care of me. So I'm really looking forward to it. Thank you. And if you see any of these people, their results are just fabulous. So thank you.
And for those of you who don't know, I mean, you do come to conferences, right, and do consultations there. You were at WLSFA last year, and...
Yes. Just look at the message board. You can check my website for upcoming meetings. Usually every 2 or 3 months we have a meeting or a conference we're going to. And at the conferences, I think even the next conference, 98% of the consultations on site are already booked.
Yeah.
So we do give consult on, but just notify our office if you really want to be seen. We'll get you in somehow.
Now, is there, and this is off script again, but is there a charge for consults to come into your office for a consult?
No, consults are free. Consults are free.
And then we've covered my next question, which was, do you think it's important to have a surgeon who has bariatric experience, which you said yes. So I'm going to just real quickly take a time to tell you guys who's watching and read a couple comments. So Brooke James is watching, and she has a question that will fit in more a little bit later. Catherine, I say her name wrong. I said her name wrong last time, so now I'm like all paranoid. I'm going to say it wrong. But Catherine Dadson is watching, and Jerry. Cerise Patron is watching, and she says, this is an amazing show. So many of my questions about plastics are being answered. Gastric Rose is watching and said to tell you she loves you. And Alicia, beautiful Alicia, says, thank you to Dr. Katzen for all your information, and thank you for your support in answering our questions. I appreciate it so much.
Sure, sure.
So.
Awesome. Okay, how does a surgeon determine what procedures should be done on a patient?
Very, very good question. And it's a philosophical question for the surgeon. There are some surgeons who the patient walks in and they already have a cookie-cutter idea of what surgery they're going to perform. And with my weight loss patients, I'm always sometimes surprised by the surgery that the person wants. So in my consultation list, I have a list of body part areas that you are concerned about. And during the consultation, we go through these body areas. And then I ask the patient, what bothers you the most? So I had, one person, actually she was another nurse, but she had lost about 300 pounds. And, going into the room, I expected she'll need the body lift and the legs and the arms and the breast and maybe the face. So I go in the room and we go through everything, and she required everything. But I asked her, what bothers you the most? And she said, well, my face bothers me the most. I'm like, okay, because usually I do face. Usually I do face last for a variety of reasons, and we'll go through those if we have time. So I did her face first. I see a lot of patients in the office, they're concerned about their tummy, and they don't need their legs. They don't want their legs done. They may need their legs done, but they're just concerned about their tummy. So how does a plastic surgeon determine what is needed? I leave it up to the patient. The patient will tell me, I got to get rid of the tummy. So to me, that means you need a tummy tuck. If the hips or the backside bother you, the love handles, or if the buttock is sagging, or if there's no butt, or if you get a lot of those Carrie de la Cruz term, shrinkles, the skin shrinks. That may mean if you have the buttock shrinkles, you may need the lower body lift or the 360. If the inner legs bother you, well, maybe you need an inner thigh lift that goes perhaps from the groin halfway down the leg, or sometimes to the knee, or in some patients down to the ankle. Just sort of depends on the legs. With breasts, most patients will say, I want my breasts back where they belong. To me, that means a breast lift.
Right.
A lot of patients will say, I want my breast fuller, but not as full as they used to be at their biggest. So to me, that means an implant. A lot of my patients will say, I want to get rid of my excess arm skin and fat. So that means an incision from the armpit to the elbow. And then sometimes a lot of patients are worried about their neck. Sometimes that can mean neck liposuction, or sometimes actually a facelift or a neck lift. Yeah. So it's really up to the patient and what bothers them as to what procedure I'm going to do.
So lots of confusion about all these things around the stomach. A tummy tuck, extended tummy tuck, lower body lift, 360. And I had a consult at WLSFA in North Carolina recently, and I went in with my friend Amy, and he told us two very different things, but then I think the quote he gave us were both for lower body lifts. And so it's like we're all kind of confused about what are the difference between these things and what works for who.
Yeah, the first part of that question is easier to answer. The second part is a little bit more difficult. Okay. So basically there are several terms, and the other problem is when you're doing these lower body lifts, there are probably about 10 or 12 different names floating out there.
Okay.
So we'll keep
it that simple. Could well be it, that we just are calling the same thing differently.
So there's the paniculectomy, okay? Pannus is the thing we're addressing. Pannus is that thing that hangs over the pubic region. So a paniculectomy is removing the pannus, okay? It's just removing the excess skin and fat of that apron. You're not, by definition, again, we're going by definitions, you're not allowed to touch the belly button. You're not allowed to fix any of the muscles on the muscle wall. It's just removing that skin and fat that hangs over. That incision may go from hip to hip. It may go from further back on the hip, but it's just removing that excess skin and fat. Okay, that's the paniculectomy. The abdominoplasty, much better procedure, much more common procedure. It's the procedure I would say most weight loss patients need because the tummy's previously been distended. Now, with the difference between the paniculectomy and the tummy tuck is the tummy tuck, I'm suturing muscles and I'm moving the belly button.
So just to clarify, abdominoplasty and tummy tuck are the same things?
Exactly.
Okay.
Yes, exactly.
Okay.
And with the paniculectomy, all I'm removing is that thing that hangs over the pubic region. With the tummy tuck, I'm removing typically from the top of the pubic line or just under the C-section scar to above the belly button, or sometimes higher. So you're able to remove a lot more with the tummy tuck, okay? But the tummy tuck's, I think, a better procedure because we address the muscle wall, we suture the muscles, the six-pack, we move the belly button, and we can get rid of more skin. Okay. The extended tummy tuck just means that incision on the side, on the hip, just goes back a little bit further. Some patients, you know, the incision on the tummy for a tummy tuck will be, say, 5 or 6 inches. For the extended tummy tuck, it may be what we call table to table. So that means when the patient is laying on the operating room table, it goes from one corner where the patient's body meets the table to the other side where the other body meets the table. Okay, so that's the extended tummy tuck. And there are a couple of other different variations of the abdominoplasty, but let's just finish out the body lift first.
Okay.
So there we go. So with the body lift goes 360 all the way around the body. So there's an incision that goes from the pubic region out over the hips and then meets in the backside. Okay.
So is the body lift and the 360 the same thing?
Yes.
Okay.
All right. Now, to make it even a little bit more confusing.
This is so confusing.
No. It shouldn't be. The 360. There's a 360 lower body lift. Okay. Or a upper body lift. Okay. The upper body lift takes care of breast and back. Okay. So that's a totally different procedure. Okay. But the lower body lift or the 360 is the same. There's also a circumferential body lift, which is the same thing. Okay. There's also a belt like the belt you wear on your pants. Belt like lipectomy. Okay. That's a little confusing because lipectomy means you're just removing fat, which is not exactly what you're doing. You're removing skin and fat, and you're tightening up the muscle. So that's a little bit of a confusing term, but most people call it a lower body lift. Okay. All right. So those are basically paniculectomy, tummy tuck, and body lift. Those are the main three.
Okay.
Now within tummy tucks, there are a couple of different types of tummy tucks. There's the horizontal, which basically is parallel with the floor, follows your belt line. There's the vertical tummy tuck, which goes from the rib cage down to the pubic region. Okay, the vertical tummy tuck. Then there's a T, which combines the horizontal and the vertical, a T abdominoplasty. And then there's another one where we make an incision underneath the breast and pull the tummy up. So those are basically the 4 types of tummy tucks we do. Yeah.
Okay.
Okay, so how do you decide which of these procedures is best for the individual patient?
Yeah, that becomes the more complicated question. All right. So the paniculectomy, I rarely advise. You know, it's not a great surgery. It's more of a debulking surgery. Like if the patient is too big for gastric bypass, we'll do the paniculectomy. Okay. So I had a gastric bypass surgeon refer me a patient. He goes, look, Tim, this patient is too big for gastric bypass. I go, too big for gastric bypass? Because when he lay on his back, his pannus was so big, it cut off the blood supply to his legs. So when he would sleep on his side. Like, okay, I understand. So for his hour gastric bypass, there would be no way for his legs to get blood supply. So I did his paniculectomy. The patient was laid on his side. I did half of it, lay him on his other side, did the other half, and I took off 80 pounds from that paniculectomy.
Wow.
Okay, big debulking procedure. He came back about 2 or 3 months later, and then they did the gastric bypass. He lost about 600 pounds after that.
Oh my gosh.
Okay, and then he came back to me for the real, not the real, but the more, but for the better surgery, I should say, the tummy tuck. Okay, so if a patient has a lot of excess skin and fat on the abdomen, I think the abdominoplasty is probably a very good procedure. Okay, if you have excess skin and fat on the hips, we need to extend that to include the hips. So either that's an extended abdominoplasty, or if your buttock bothers you, excess skin or excess fat, usually it's excess skin because the butt has sort of disappeared, then I would convert that tummy tuck into a body lift, extending that incision not just to the hip, but all the way around into that 360 lower body lift. Yeah.
Okay. So, and this is another question I just thought of. What percentage, just because you mentioned a man, what percentage of your practice is men versus women?
Yeah, about 25% of my practice are male weight loss patients. Okay. Males, you know, we treat them a little bit differently in terms of incision placement and their physique, because obviously it's different.
Right. Okay, I'm just going to tell you a couple more people who are watching. Dennis Vinay's watching, Christina Rangel's watching, and Laura Van Tool posted that she had surgery with you 10 years ago, and he was the best then as he is now. He is the most truly kind surgeon I've ever met. He really wants us as his patients to live healthy and thriving lives. He is worth taking the trip to California.
Yay, well, thank you. Yay.
So we still have a lot of questions. We only have 15 minutes, and I want to respect your time, but do you maybe have a few more minutes if we go over by maybe 5 or 10 minutes?
Yeah,
okay.
No problem.
All right, because we've only talked about the stomach, and there's all these other body parts that you mentioned. So arms are a big concern for a lot of people. What are the risks from having a brachioplasty? Is that how you say it?
Yeah, brachioplasty, which basically means an arm lift. And a lot of people will call it an arm tuck. Basically, it's confusing. It's an arm for real. For the real surgery that's being done is an arm reduction. Okay, I'm removing excess skin and fat. Sometimes, rare, all I do is liposuction, but that's maybe less than 5% of weight loss patients. You need to get rid of excess skin and fat. Sometimes an incision will be made in the armpit, and the area that I remove looks like a crescent or a piece of cantaloupe or a smiley face.
So is that a crescent lift?
Crescent lift.
Okay, because I need that too. Okay. I had never heard of that before. Okay.
But the problem with that is it doesn't remove a lot of skin from the middle 1/3 of the arm, and it doesn't remove any skin and fat around the elbow. So if elbow skin and fat bothers you, the incision really has to go from the armpit to the elbow. Okay. And in my practice, I would say about 80% have an incision that go from the armpit to the elbow.
Now, the person who asked this question was a massage therapist, so she was particularly concerned about nerve damage and recovery time.
Yeah. Nerve damage is always a possibility, but in my practice, it's definitely probably less than half of 1%. It's extremely rare. There are two main nerves in there. One's a sensory nerve, one is a motor nerve. But in terms of nerve damage, the nerve that she's mentioning in terms of motor and being able to massage, I've personally never damaged that. It's there, could happen, yeah, but it's pretty rare. Now, for my arm lift patients, or arm reduction patients more accurately, I usually say you're able to go back to work usually in about 2 weeks, okay? That's for most desk jobs. Now, if you do a significant amount of lifting, if you're a construction worker, if you work at Home Depot, if you do a lot of massage therapy, I would say maybe delay that return to work maybe 3 weeks after the surgery or perhaps 4 weeks after the surgery, because those patients use their arms a lot more.
Is it possible to have the surgery done when the scars are hidden? Or to make the scars so that they're hidden, the arm scars?
Yeah. Now, that's a very common question. Seems like I'm answering that question almost once or twice a day.
Yeah.
What I think should be done, as we all are in the interview right now, all our arms are down by our side. It's rare that our arm is up like this. Maybe if you're a school teacher, maybe the arms are up like that. But if your arms are down by your side, you should hide the incision. So when the arms are down by the side, you rarely see that incision. If you think about seams on a suit or seams on a shirt, that's where you should hide your surgical incisions. Now, technically, it's a lot easier on the arm to put the incision on the back of the arm where the tricep is. But when your arms are down by your side, boom, you can see that scar right away.
Mm-hmm.
So what I do is I put the incision between the bicep and the tricep, right on the inner portion of the arm. Okay? So when you hold your arm up and you make a muscle, between the bicep and the tricep, there'll be an incision that goes from the armpit out to the elbow. So when your arms are down by your side, you don't even see that scar.
Now, we can hear you, but, oh, there you are. You're back. Okay, we could hear you, but we couldn't see you. But there you are. Okay.
Internet glitch, who knows?
Yeah, that's no problem.
Solar flare.
So we had a specific question about could you do your arms and your breasts at the same time, but I'm overall just kind of curious. You mentioned all these different areas. What do you usually do at the same time?
Sure. Typically, we stage these. Now, physically, I can do all these surgeries in one surgery, but it's not advisable.
Mm-hmm.
I don't know any single surgeon that's doing these procedures in one get-go.
Mm-hmm.
One, it's not a good idea because you have all that length of incision. Two, there is blood loss. You'll probably wind up with a blood transfusion. So most of my patients, we don't need to do blood transfusions. We stage these procedures, and that's the common treatments and the treatment for weight loss patients. So typically I do the tummy tuck and or the body lift, the lower body lift. Sometimes with legs, sometimes without legs. If the legs are relatively small, I'll do the legs at the same time as the body lift or the tummy tuck. If the legs are very big, I'll do the legs maybe about a month or 6 weeks after the tummy tuck or body lift. Then about a month or 2 months later, we'll move to the upper portion of the body where I'll do arms and breasts at the same time. Okay. And then either the second or the third procedure, or the third or the fourth procedure, will then either be the facelift or the neck lift.
Mm-hmm.
Yeah. But I commonly do breast and arms at the same time. I don't like to do arms and tummies and arms and legs and arms and body lifts at the same time because you need your arms to pull yourself out of bed. You need your arms to sort of get up and go to the bathroom. So that's why I do arms usually last or second to last in my staging of the surgeries.
And is it also relatively common, because this is what I hear people doing a lot, is the stomach and the breast at the same time?
Stomach and the breast, yeah, it's very common. Yeah. It's in the media and the press, it's called a mommy makeover. You know, it's just a term we're stuck with, but you know, it addresses the tummy and the breast in one surgery, and that's very reasonable to do those at the same time. Yes.
Okay.
Okay, and on to the breasts. Because our breast tissue is different than someone who has not experienced major weight loss, are there any additional factors that we have to take into consideration when choosing between silicone and saline implants?
Very good question. In my practice, I think silicone implants are really the best implant. They feel more natural, they look more natural, less capsular contracture with where we put the implant. So I think overall the silicone implants are a much better choice. Now, if the salines rupture or the silicones rupture, you still need to take them out and replace them. If the saline implant ruptures, your body absorbs all that saline and, you know, no harm, no foul. If the silicone one ruptures, you'll get some pain in that area. We'll work it up with an MRI or a mammogram, and we'll see the silicone leakage and still take that implant out. So in my practice, most of my patients, probably 98%, will opt for the silicone implant because I think it's just a much better implant. Yeah.
Now, and do these, because I'll speak for myself in saying I'm on the upper end of age for weight loss surgery patients, generally at 49. In this community, we have a lot of people who are really young. Or if they're getting implants, are they going to have those redone every 10 years, or how does that work?
No. No. My philosophy, and I think most ethical plastic surgeons will say, if it ain't broke, don't fix it.
Mm-hmm.
Okay? So that means if you're not having any problems with the implants, just leave them alone. They're fine. I've had women come into my office who I've not done their breast implant surgery, but they say they've had the implants in for 35 years. I'm like, well, are you having problems with the implants? They say no. So I say, well, you don't need any surgery unless you're having problems.
Mm-hmm.
Yeah.
And what about breastfeeding? Is there any kind of complication with having implants prior to breastfeeding, or should they wait till after they're done having kids?
Yeah, usually my statement for pregnancy and having children is, if you're planning on having kids in the next year, in the next 12 months, wait on all this plastic surgery.
Mm-hmm.
If you don't know when you're planning on having kids, you can go ahead and have the tummy tuck and the breast lift and the breast implants. Now with breast implants and breastfeeding, approximately 80% of my patients have been able to breastfeed after the implants. It really depends, you know, the size of the implant, the approach, the amount of lifting that needs to be done, but pretty good chance that you'll be able to breastfeed after the lift and insertion of implants.
Okay.
Okay. Are there any complications having breast implants when the skin has stretch marks?
Not really. I mean, the stretch marks basically just tells us the integrity of the skin, how much it's stretched out, and how much a lot of these elastic fibers have been destroyed. But the presence of stretch marks really don't, you know, predict how much we have to pull, or basically don't contraindicate, you know, doing a breast lift or a tummy tuck. So stretch marks, you know, they're just part of the picture. A lot of them can be removed with surgery if they're in the surgical field. But if you have stretch marks, doesn't really mean we should use one implant or another, or do a certain lift and not the other.
Mm-hmm. So the thing that bugs me the most, but I still probably wouldn't have this done first, but it does bug me the most, is my face and my neck. After losing all this weight and looking so much older than I did before. What can be done for that? I mean, what are the recommended procedures for that?
Sure. There are a couple of different things that we do. I have a lot of patients that come in complaining of neck.
Yeah.
Neck, right? Turkey gobbler. Okay.
Yep.
And I had a wonderful classic patient about maybe 14, 15 years ago, and she had lost about 200 pounds, 250 pounds. And she had turkey gobbler neck, and our plastic surgery training tells us those patients need a neck lift or a facelift. I go, you know, you're 20 years old. I am in Beverly Hills, but I really don't think we should do a facelift on you. So what I did is neck liposuction and got a really good result. And the important thing about that is wearing the garment underneath the neck after the surgery. So on a lot of my weight loss patients, I'm doing this neck liposuction, and patients get great results from it. Moving on up, we can do a facelift where the incision goes just around the ear and then around the back of the ear, and it lifts up the cheek bone that has fallen, lifts up that skin and fat, and gives the face a lifted look. Things we can do for the brow as the eyebrow comes down. Sometimes we can do a brow lift. The incision goes across the forehead or in the hairline, and we can raise the brow up. Some things we can do also is we take fat from elsewhere, tummy or legs or backside. We inject it into the temples because some patients lose so much weight their temples go in. Sometimes we inject it into the forehead, nasolabial folds, to plump out the face. Faces look more youthful when they're round and have a lot of fat in them. So to rejuvenate the face, sometimes we're returning fat to the face.
I wouldn't trade it, though. I'd rather look a little older.
Yeah, can I interject a question on that? If you're injecting or moving fat, does that fat stay in place, or does it dissipate over time?
No, it stays in place. We can get pretty accurate with the fat we place in the face, forehead, nasolabial folds, temple, breast, and buttocks. And that fat usually stays around for, it depends. In the face, it stays around even a lot longer. But even in the buttock and the breast, about 80% of the fat that I inject lasts for at least 3 years or longer. So that's a pretty good amount of time. So, and the fat doesn't move around. It should stay right there. Yeah.
Okay. So oh no, it's you. It's on you, Patti, and I don't even know what that is.
It's
That
me.
question is.
Okay, I know. I've never heard of this. Someone asked specifically about Glabellar injections. Is that something that can be used to help with sagging skin in the neck and the face?
Glabellar basically is the it's the area right between the eyebrows. All right, and people it's pronounced glabella with a G.
Oh, okay.
And basically, it's when you frown, it's that area between the eyelids.
Oh, okay.
Okay.
The 11s?
The 11s, exactly. The 11s. And
we lost your video.
This area sort of right.
Okay.
All right. There we go. It's right between the eyebrows.
Okay.
So typically, the best treatment for that is going to be Botox. Okay. Botox paralyzes the muscles in that area, and basically it prevents you from making those 11s. Another thing, if it really bothers you and you're sick of just having Botox injected, sometimes we'll fill it in with fat. Okay, we'll get fat from the arms or the sides of the tummy and inject fat into that area. If it really, really, really bothers you and the Botox isn't working and the fat transfer is not working, I'll do a forehead lift and come down from the inside and actually resect a little bit of that muscle in there as it inserts into the skin. And that completely eliminates the glabellar frown, or the number 11s. But it's glabella, Glabella.
Okay,
yeah.
Got it.
Thank you.
Now, do you feel like, we talked a little bit about the fat transfer, do you feel like there are alternatives like Botox that are better than doing the fat transfer?
Now, they address different things.
Okay.
Botox is botulism toxin. It's a poison, but we've sort of controlled it, and like a lot of vaccines and stuff like that. And Botox paralyzes the muscle, so we use it to control wrinkles, among other things. There are dynamic wrinkles, and there are what we call static wrinkles. Dynamic wrinkles are wrinkles that occur when you contract the muscle. So take the number 11s. As you bring your eyebrows together, if you get wrinkles in there, and they're not there when you're not bringing your eyebrows together, that's a good treatment for Botox. So if you get wrinkles that aren't there naturally, that's a good treatment for Botox.
Okay.
So Botox is good for crow's feet, forehead, number 11s, and out to crow's feet. That's the best treatment. I don't suggest going underneath the eyes. I don't suggest going around the mouth. There can be a whole host of problems. So Botox fixes wrinkles that develop when you contract the muscle. Fat transfer, on the other hand, corrects wrinkles that are there just sitting there. Whether you bring your eyebrows together or raise your eyebrows up, wrinkles that are there just naturally. The typical wrinkle that we inject it into is the nasolabial, from nose to lip, nasolabial crease. We inject in that fat because that wrinkle is there pretty much whether you smile or don't smile, it's sort of there. So we fill up that wrinkle with fat. So those are the best types of wrinkles to treat with fat. Wrinkles that are there that don't get worse with facial contracture. Yeah.
Very good. Okay, it looks like we're going back to the body here. Can any procedures be done without an epidural? And if so, which ones?
Now, sorry, with an epidural or without an epidural?
It says without, but I think maybe she means with.
Oh, okay.
Yeah.
Versus general anesthesia, yeah.
Yeah, now an epidural basically goes into the dural space, which is basically the space that communicates with your brain. So in my practice, 15 years, thousands and thousands of patients and thousands of surgeries, I've never had to use an epidural before.
Amen. Thank you.
Yeah, I don't. Now I know a very reputable plastic surgeon, and that's what he does, and that's great. But it's more for post-operative pain, okay? And it also does, does decrease the chances of blood clots. But I think the easiest way to do the surgery is with general anesthesia, completely asleep, and then we go ahead and do the procedure. Now the epidural typically is used post-operatively to control pain control. The epidural, is a needle that's injected into the spine, and it numbs everything beneath that spine, if you will. I guess if you had a high enough epidural, you could probably do a tummy tuck. You could probably do a leg lift. But in my practice, I wouldn't suggest it.
Okay.
Yeah.
So we had a couple of kind of specific questions, but because they're from people who are really active in this community, if you have a minute or two, I'd just like to get them in that were specific to their situation. So Gastric Rose, who's one of the people who had surgery, I don't know how long ago, like 10, 12 years ago, and is still participating in the YouTube community, is really amazing. But she, I guess, had a bad staph infection from getting MRSA in the hospital that took over a year to get better, and she wanted to know if another surgery would be possible for her. And I think that was as a result of the plastic surgery that she already has had.
Yeah. Yeah. Now, that's a very difficult question to answer because there are different philosophies regarding MRSA. MRSA is this methicillin-resistant Staph aureus. Basically, it's a skin bug that has become resistant to a specific antibiotic. Very hard to treat. Sometimes you need IV antibiotics for weeks and sometimes months. Now, in the infectious disease community, and I have very good friends who are infectious disease specialists, the doctors, the specialists that treat MRSA. There's even debate among those doctors as to MRSA. There's one school of infectious disease specialists who believe that once you have MRSA, you have it for the rest of your life. It's in your bloodstream forever and ever and ever until you die. There's another school, and I'm sort of in this school, that believe that you develop MRSA, you treat it with antibiotics, and it's gone. You can get it again, but you know, you're probably at a little bit higher chance of getting it again. But if you get it, treat it appropriately, nasal swabs, we make sure it's out of your system, I think it's probably gone. So this patient in particular who had MRSA in the hospital before can, I think, have plastic surgery again. She or he is at a higher risk of developing MRSA again, but it shouldn't deter her too much from having her plastic surgery. Yes, consult with your internist. Make sure she's medically cleared for the procedure. Yes, consult with an infectious disease specialist to perhaps have IV antibiotics of a specific kind, vancomycin, before and after the surgery to really minimize the flare-up of that MRSA. Yeah, but really good question. Yeah.
Okay.
Okay, Dr. Katzen, have you ever worked with patients who have previously had mastectomy reconstruction?
Yes. Did one patient last week.
Wow. Okay.
So it's very not very common, but it does happen. It does occur. Yes.
Okay, great. So we have somebody in the community who had tram surgery in 2007, and she would like a lift and a tummy tuck, and so she wanted to know if this was a possibility for her.
Yeah, I think it is. You know, not examining the patient, not seeing her pictures, I would imagine she probably would be a candidate. Just because you have breast reconstruction with the tummy skin and fat, a tram flap, doesn't eliminate the chance of maybe a mini tummy tuck or a modified tummy tuck, or at least getting rid of some of the excess skin and fat of the abdominal wall. And just because you have one breast procedure doesn't mean you may not need another breast lift or revision of the breast site at a later date. Yeah, so she could probably have both, not having examined her. Yeah.
And one last question, and I know we had tons of questions about this. I know you're a surgeon, not an insurance specialist, but people wanted to know if you had any suggestions on how they might conceivably get their insurance companies to cover their plastics.
Yeah, that's a very tricky question to answer, and what makes it even more confusing is every state is different, and every insurance company is different, and even within insurance companies, people can have different levels of health care, unfortunately, if you will.
Yeah.
So, as a generality, I would suggest document everything. Okay, if you have a rash, take a picture of it. Date it, time it. Anytime you see a doctor, date it, time it, get a copy of it. Any medication you buy for any rash, whether it is a powder or a cream or anything, document it, take a picture of it, take a picture of the receipts. Now, I would go to a plastic surgeon again who has experience with weight loss patients and is willing to work with insurance companies. I have a lot of friends who are board-certified plastic surgeons, and they don't take insurance whatsoever. Boom. They don't even want to deal with it. So that's already eliminated. Then if you get a plastic surgeon who doesn't have a lot of experience with working with the insurance companies, they're going to write a letter, but it's not going to be a strong letter, and they may not use the right terminology for an insurance company to approve it. So those are, very important things. And then again, some states have different laws about plastic surgery. Medicare doesn't approve a lot of reconstructive surgery after weight loss. There are some insurance plans which categorically within the policy say, if you have had gastric bypass, plastic surgery is not covered, period. That's it. So that's very difficult to work around if it's stated in the policy to that effect. But all I can suggest is, document everything, keep a copy of everything, and when I submit to the insurance companies, I ask the patient for all this documentation. We had one patient from Utah, lost a lot of weight, sent it to your insurance company, and everything was denied. She needed a body lift, she needed the legs, the breast lift, the arms, she needed everything. We wrote a very strong letter, pictures and everything, and unfortunately it was denied. But what I told her is, you need to call your insurance company. You need to provide them documentation. So over the course of about 3 or 4 months, she provided documents that were about 4 feet high. Pictures and papers and medical records and everything. And she sent them by certified mail to the insurance company. And wouldn't you know it, in about 48 hours, all her procedures were approved.
Wow.
Okay?
Amazing.
And she had the surgery. Now I'm thinking, okay, 48 hours, that's, 2 days, that's 16 hours of a work day. It took them 16 hours to go through 4 feet of paperwork. I don't think so.
Yeah.
I think they saw that paperwork and said, this
And
is
went,
ridiculous, just to prove it. And they did. And we're only human, and that's what happens. The other thing that I've seen is I've had patients who call their insurance company sometimes 2 or 3 times a day, bugging them, why isn't this approved? This has been, this is the policy, this has to be covered. And eventually the insurance companies do give up, and basically I had a patient about 2 or 3 weeks ago. That exact same thing happened. Initially, everything was denied. She kept bugging him and bugging him and bugging him, and then eventually everything was approved. So, there are ways to push the insurance company to cover what they should cover.
Yeah, and don't just give up. I mean, document it and be ready to appeal the decision and follow up with them and bug the crap out of them.
Exactly.
Great.
Well, I think that pretty much wraps up our questions that we have written down here from everyone in the community. I know we're getting some from outside, but Dr. Katzen, we can't thank you enough for being here tonight. We really appreciate it. Sharing your knowledge. We love it, and we're so honored that you would join us. And I'm sure there's a lot of people in our community that would love to get in touch with you to have consultations. What's the best way for them to get in touch with you?
Probably just call the office, which is 310-859-7770. There's also, if you just go on Google and Google my name, all our websites will pop up. One of our main websites is 360 Body Lift. That's 360bodylift.com. Then, my name is another website, so you can find me definitely on the internet. But, if you want to schedule an appointment, call the office. We can do Skype consults. We do a lot of Skype consults with patients all over the U.S., all over the world, and that can save a lot of time and money and effort on patients' parts.
Well, we are just so great, and I'll put all that information below after the video post, but we're just so grateful for you taking the time. This has been so helpful, I know, to me personally to get a better understanding. This is just a subject that there's so much confusion around in the weight loss community, so we are so grateful for you for being here tonight.
Well, thank you very much for having me. Thank you very much.
And you're welcome to hang out for a minute or two. I'm going to do our community celebrations, or you can, peace out if you'd like as well.
Okay. All right. I'll hang out.
Okay. Well, so we just every week we like to recognize things that are going on in the community for the people who are part of it. So I want to do that really quick. Dennis Finney hit Wonderland. He looks amazing. Christina Rangel finally got her surgery date, and she's been waiting and working really hard at that for a long time. Little Aussie Mel celebrated her 2-year surgiversary. Susanna RNY Diaz celebrates her 1-year surgiversary next week. Kylie Chasing Dreams hit her goal 3 weeks ago and celebrated losing 70 kilograms. She's an Aussie, so that's 154 pounds.
Wow.
Carrie Groves McGuire, her 19-year-old, got through a lot of clothes that she could no longer fit into, so she inherited some sizes 10s and 13s, which is awesome. Sarah Harrison Robinson is back in the 220s. She had a baby. Her baby's like the same age as my granddaughter, so a little over a year old. And so she's back in the 220s. Barbara Zook, who is the mom of Mom and Me VSG, has gotten 5 bars on her Fitbit all week, which is great. Amy Greider, whose YouTube name is Switched Focus, hit Wonderland this week. Tanya TK Evans, I can't remember what her YouTube name was.
TK Sleever.
TK Sleever. So she is a nurse who just got a new job as coordinator of the metabolic and bariatric surgery program at her hospital, which is awesome. And I think Sarah Waffle got a new job too, so I want to send her a shout out for that. And New Me Natalie and Killing Fat Amy are both having their VSG surgery on Monday, so we want to send them our best wishes. So those are the shout outs I have for this week.
Congratulations, everyone. For next week, we've got two weeks worth of shows that we want to tell everyone about. Next week, Jennifer Bleacher will be hosting along with Tanya O'Rourke, or Tanya VSG 2011, and their guest will be Jim Haney. And then on November 22nd, Elizabeth will be back, and she will be co-hosting with Jennifer. And their guest will be Matt Harker, who is a weight loss surgery patient who actually isn't part of the online community, but he has an amazing story. And so looking forward to introducing him into the community and sharing his story. And
okay, and thanks everybody for watching. Don't forget, like, share, and subscribe. We need to get our subscribers up so we can go to YouTube Space LA and maybe film a show with Dr. Katzen in person.
That'd be great.
All right, thanks, guys.
Thank you, Dr. Katzen. See you later this week.
Thank you.